So the highlights of our session is all practical aspects of pediatric kidney disease CKD will be delivered by experts, and the polling session for trainees are open with a cash reward, and the instruction of the polling session will be done towards the end of the session. We also have the CME credit cards for our Indian nationals. So it is an honor to introduce Dr. Girish Bhatt. He is a professor, Department of Pediatrics, and his area of interest is towards tubular disorders, childhood hypertension, and acute kidney injury, and also on evidence-based medicine. He's a recipient of a prestigious ICMR International Fellowship 2017, and he is also a mentor of International Pediatric Nephrology Association Clinical Society Academy, and he's also a member of IPNA Evidence Review Team. He's authored a lot of guidelines, and he is also a member of Cochrane Kidney and Transplant. He's got a lot of national and international publications around 114, and he's also a recipient of prestigious Sheher Award for this year 2025. And it's a great honor to introduce Dr. Girish Bhatt, and over to Dr. Girish to introduce the speakers.
Yeah. Thank you, Dr. Kalavani, and congratulations to your team for running this webinar series successfully. So today we have two speakers. So I'll introduce the first speaker. Can I have the slide, please, of Dr. Caroline? Okay, so Dr. Caroline Suyin, she is the ESPN board certified pediatric nephrologist in the hospital Tengku Jaffer in Malaysia. She is a member of the editorial board of the World Journal of Nephrology from 2022 to 25. She's the president of the Persatuan Pediatric Hospital in the Tengku Jaffer, Malaysia. She's the vice president of the Malaysian Society of Pediatric Nephrology. She has many awards to her credit, like Excellence Service Award in the year 2007, Young Investigator Award by the Malaysian Society of Nephrology, First Prize Award for the Nagari Seminar Research by the Post-Study in 2023, and the Distinguished Clinical Service in Pediatric AKI Award by the International Collaboration of Nephrologists and Intensive for Critical Care in Children. She has over 30 research publications. So over to you, Dr. Caroline.
Thank you very much, Professor Girish, for the very kind invitation, and thank you, Dr. Kalavani, for this invitation. I feel very honored to be able to speak in this platform of yours. So I think without further ado, let me share my screen. If you can see my screen.
Yes. Yeah.
Okay. So I have been given this task to talk about drug handling in children with reduced kidney function. And I have nothing to disclose except the fact that I'm not a renal pharmacist. An overview of the topic: kidney function plays a crucial role in drug metabolism and excretion. And when managing children with reduced kidney function, be it chronic kidney disease or acute kidney injury, this becomes a challenging task that requires careful consideration and meticulous planning. Resources are available to assist in dosing decisions for patients with CKD. Nevertheless, it is relevant for clinicians to grasp some of the basic principles to assist them in better prescribing practices. This picture here illustrates very well the pediatric pharmacokinetics itself is complicated with the evolving maturational processes. Reduced kidney function complicates dosing consideration further. So before we move on, we would like to have a look at what happens when drug is ingested, either via oral route or given via intravenous route. We have the four major processes in pharmacokinetics: the A, D, M, and E: absorption, distribution, metabolism, and then elimination. So whether the drug is given intravenously or whether it's taken orally, then there must be some mechanism for the body to absorb the drugs. And that is when we talk about the concept of bioavailability. In the systemic circulation, then we need to consider protein binding. and because only free drugs are actually active. And we will touch a little bit on volume distribution later on, whether they are lipid soluble or water soluble before they being metabolized, whereby the liver would be the major organ for drug metabolism. And finally, we talk about elimination of drugs. So in CKD, the gastrointestinal edema may limit drug absorption. In the state of uremia, this may induce a vomiting and slow gastric emptying time, and this would definitely affect drug absorption as well. Medication commonly prescribed to CKD patients, phosphate binders, may affect the absorption of certain drugs, for example, ACE inhibitors like captopril, oral irons, antibiotics, fluoroquinolones, and as well as thyroxine. In the pre-dialysis advanced uremic state, the salivary urea produces an alkalinizing effect and may decrease the absorption of drugs which are actually optimally absorbed in acidic milieu. So these are some of the conditions whereby CKD may affect drug absorption in the child. When we also know that only free unbound fraction exerts an effect, hence higher fraction of unbound hydrophilic drug would lead to potential toxicity when there is a reduction in elimination. Protein binding is altered in the state of CKD. Hypoalbuminemia in nephrotic states will affect protein binding capacity. Presence of uremic toxin displays drugs from binding site, and highly protein-bound drugs, in fact, may compete for limited binding sites, hence leading to an enhanced effects or adverse reaction. So all these would then justify dose adjustment and therapeutic drug monitoring when we handle patients with a reduced kidney function. What is the volume of distribution? Volume of distribution refers to the proportionality constant, and this relates to the total amount of drug in the body to the plasma concentration of the drug at a given time. So the volume of distribution in liter in simple terms would be the ratio of the amount of drug in the body over the plasma concentration. When there is an elevated volume of distribution, it means that there is a propensity for the drug to leave the plasma and enter the extravascular compartments of the body. So a higher dose of a drug is required to achieve a given plasma concentration, which means higher volume of distribution leads to more distribution to other tissues. When there is a low volume of distribution, there is a propensity to remain in the plasma, meaning a lower dose of a drug is required to achieve a given plasma concentration. In other words, low volume of distribution would lead to less distribution to other tissues. A drug's volume of distribution is determined by tissue binding, plasma protein binding, and lipid and water solubility of the drug. So lower volume distribution leads to higher drug peak concentration. For a hydrophilic drug, this volume of distribution would increase in the several conditions. Edematous states in CKD patient, when our patients are down with infection or when patient has ascites. Volume of distribution reduces in the state of cachexia or muscle wasting, and also when there is volume depletion. Metabolism, like I've said before, is primarily of hepatic function. But in CKD, the reduced glomerular filtration rate slows down drug metabolism due to decreased cytochrome P450 system. And some of these isozymes in that cytochrome P450 system contributes to over 50% of CYP-related drug metabolism. The kidney may be involved in clearing active as well as toxic metabolites, and these metabolites may accumulate in patients with CKD. Renal clearance is the net result of three processes: filtration at the glomerulus, passive reabsorption in the tubules, and of course, one of the easily forgotten function of proximal tubule, which is the active secretion of drug via the organic anion transporter. So when GFR falls, there's a fall in clearance of drug as well, which in other words, the half-life will be prolonged. One good example would be the low molecular weight heparin, enoxaparin or dalteparin, whereby kidney clears this drug more than unfractionated heparin. Hence, there is an increased risk of serious bleeding. So some of the consideration, if you really need to use low molecular weight heparins in patients with severe kidney function, though it is not advisable, you may want to be guided meticulously by the anti-10A activity. Or you can always choose for a safer option, alternative anticoagulant like tinzaparin, which does not accumulate in CKD patients with crack clearance of more than 20 mL per minute after even 10 days of dosing. The other example of drugs that I would like to illustrate here, and we use this drug often in our practice, would be morphine. Morphine is metabolized in the liver, and we know that some of the metabolites, the morphine 3-glucuronide as well as morphine 6-glucuronide, they are excreted by the kidney. How are they excreted by the kidney? 70 to 80% of morphine is excreted in the urine, 10% excreted in the feces, and less than 10% excreted as unchanged drug. And the morphine 6-glucuronide, which is the active metabolite, this actually depresses the central nervous system, and it will be excreted by the kidney as well. So in the state of a reduced kidney function, these atoxic and active metabolites will accumulate and crosses the blood-brain barrier. And the CNS effects are actually prolonged, potentially mediates respiratory depression. Hence, in patients with reduced kidney function, a preferred opioid would be fentanyl rather than morphine. So how does reduced kidney clearance in CKD then impact our dosing of drugs, especially those eliminated by the kidney? We know that it takes about 5 half-life for a drug to reach its steady state concentration, and this is going to be substantially longer in CKD. Hence, justify the role of a loading dose, which is the desired plasma concentration multiplied by the volume of distribution. Assuming that the volume of distribution remain unchanged, this loading dose does not need to be modified in CKD, which means that the loading dose should be given as the normal dose, not adjusted. Then, before we move on to how we decide on the maintenance dose, we need to understand the concept of the fractional drug or metabolite excretion in the urine. We look at this diagram here, we can see a particular drug, for example, 10% of the fraction of the drug excreted unchanged, about 50% may be metabolized into an inactive metabolite. We label it as M1, and 100% of them excreted by the kidney, but this is an inactive metabolite. 30% metabolite 2, which is an active metabolite, also 100% excreted by the kidney, and the remaining 10% cleared by the biliary system. So we conclude from this diagram here that the total kidney excretion of the drug dose is about 90, 10 plus 50 plus 30 is 90%, but fraction of drug excreted unchanged and active metabolite by the kidney would be about just 40%. So all these parameters would be easily obtained if we have access or parameters are available from dedicated drug PKPD studies. And that would actually help us to guide our drug dosing modification if clinically necessary. So when it is necessary, a drug is considered to be substantially eliminated by the kidneys when the fraction of systemically available drug or active metabolite that is eliminated unchanged in the urine is 0.3 or 30% or greater. So in other words, fraction of normal kidney function to use in kidney impairment would be equal to the 1 minus fraction of excretion multiplied by the 1 minus fraction of your normal kidney function. For example, if we have a drug here, XYZ, that is 50% renally cleared, unchanged in the urine, to a person with 30% of normal kidney function, then we say that the fraction of normal kidney function to use in kidney impairment state would be 1 minus 0.5 times with 0.7. That would be 1 minus 0.35 or 65% of the normal dose. So maintenance dose can be dose guided by a few principles. It's either we reduce the dose or we prolong the interval, or we can do both ways. Prolongation of interval would allow for adequate peak concentration, but this may actually pose some risk of subtherapeutic trough levels. Dosage reduction seems simple, but this will keep drug levels more constant, but it does increases the risk of toxicity from higher plasma trough concentration. When our patient moves into the state of needing dialysis, then we need to consider drug removal during dialysis. So our patients may receive various modalities of dialysis, hemodialysis, peritoneal dialysis, and when they become unwell, they may also receive continuous kidney replacement therapy. So in hemodialysis, then we need to consider that drugs are removed via diffusion, mainly via diffusion. And of course, there is some convective mechanism here in hemodialysis. Also, when the solvent drag, the dissolved solutes are being dragged along. So what are the factors affecting drug removal during dialysis? The blood and dialysate flow rates and the length of dialysis, molecular size of the drug, typically dose less than 500 kilodalton, drugs that are which has low protein binding or with a low volume of distribution, drugs which are water soluble or in other words low lipophilicity. And of course, we need to consider the type of membrane we use for hemodialysis or permeability of the membrane. The high flux membrane clears drugs better than the low flux membrane. And semi-synthetic and synthetic dialysis membrane clears better than the natural membrane. We also need to understand something about post-hemodialysis equilibrium, whereby the body attempts to equilibrate between blood and tissue. So when we have a peak concentration and post-hemodialysis, you will see that the true post-HD concentration would be lower because there will be a 4 to 6 hours of redistribution phase, whereby there will be a post-dialysis fluid shift. So it is not it is unreliable drug concentration for about 4 to 6 hours post hemodialysis, while the body tries to achieve equilibrium. So how do we put all this into clinical practice? You will realize that most often we are asked to dose drug post dialysis if possible, especially antibiotics. And if significant amount of drugs are being removed via hemodialysis, a supplemental dose after HD may be warranted. So in a typical picture, like illustrated in this diagram, 4 hours of dialysis, you would be able to see here that we would usually withhold drugs, especially antihypertensive agents, before the dialysis due to its dialysability. If you need to check drug level, the day should be checked pre-dialysis. And some drugs, for example, anti-epileptic Keppra, may need a supplemental dose post-dialysis. And most antibiotics should be administered after dialysis because of its significant hemodialysis removal. Patients on peritoneal dialysis, less quantity of drug removed in PD compared to HD. Hence, supplemental administration of drugs is not necessary in patients receiving continuous ambulatory peritoneal dialysis. But for our children who are on automated peritoneal dialysis, the drug clearance may be more enhanced than CAPD. And similarly, we also need to consider when patients with residual urine output versus those who are actually anuric. When there is a state of peritonitis, intraperitoneally administered drugs actually enters the circulation more rapidly and completely due to the increased permeability of the peritoneal membrane. So a significant amount of drug is being absorbed from the peritoneal cavity, which justify the use of intraperitoneal antibiotic when we have peritonitis. Thus, it is also a prerequisite for rapid drug elimination by CAPD, which is a low body volume of distribution of that particular drug, and that drug diffuses into the peritoneal space to a significant extent. It becomes more complicated when our patient is down with an illness and becomes hemodynamically unstable and requires continuous kidney replacement therapy. So we have multiple modalities here, either a post or a pre-dilution hemofiltration and also hemodiafiltration. And similarly to the hemodialysis, drug clearance depends on molecular weight, volume of distribution, protein binding, membrane adsorption, because if you're using the filters with AN69, then we also get some membrane adsorption there, molecular charge, as well as whether they compete with other elimination pathways, i.e. non-renal or hepatic clearance. And we can see here the higher flow rates actually clear drugs better compared to those when it is run at a lower flow rate. So dosing becomes very challenging, and in this difficult situation, drug monitoring is the key. Drug monitoring is important in patients with CKD, especially for drugs with a narrow therapeutic window. Most believe that we cannot work alone, and we really need our colleagues around us, our renal pharmacies, to help us with our drug monitoring. So the peak drug level would be the highest drug concentration achieved after initial distribution, and this predicts drug's efficacy, while the trough drug level, which is immediately before the next dose, predicts toxicity. So when our patient is in an ill state, drug monitoring becomes very important to help to guide us with our dosing. And with time now, we have a whole huge references on many types of drugs, especially those with narrow therapeutic index, which require routine monitoring. So as a clinician, we try to put everything into practice. We should always start with a detailed initial assessment, identify if the key dysfunction is acute or chronic. Then we estimate our GFR. In the adult world, the guidelines suggest calculation of the GFR or crack clearance with the Cockcroft or MDRD method. But I think in many pediatric references, they are actually cited for clearance with using a bedside Schwartz method. But I think what is more important is the trending, and stick to one calculation that is most easily available and accessible, so that it doesn't change with time. Then we corroborate drug dosing with GFR. And of course, finally, if you're going to load the patient, the first dose, especially antibiotic, it should be the same as normal kidney function. So we give the normal dose because we need to achieve that steady state concentration fast. And in the state of CKD, that half-life is usually prolonged. And subsequently, for the maintenance dose, we know that we need to adjust the dose. Either we reduce the dose, or we prolong the interval. And this is guided by how best the method promotes efficacy. So a very close communication with our renal pharmacies is very important. Dedicated renal impairment studies performed and ongoing initiatives are recommended, as impaired renal function is likely to alter the pharmacokinetics of the drug or even its active metabolites, because the kidney substantially eliminate them. So thanks to all these pharmacokinetic studies, now we have a huge resources easily accessible to all of us. I've put up a few here. The one on my top left is actually from the Great Ormond Street PITS ICU, where it gives you a dose adjustment in the renal impairment, pre-dialysis state, and when you are on dialysis, depending on the modality, how you should adjust your drug. So all these informations are actually put up based on the principles that we have earlier discussed. Then we also have the Johns Hopkins Antibiotic Guide, the BNF Children, and of course, Kinder Formularium. Then we also need to ask ourselves whether a patient is on dialysis. If the patient is on dialysis, we need to take into consideration the effect of dialysis on drug dose and whether a supplemental dose is needed. And always consider drug-specific safety monitoring. We need to think about TDM. That would be the best practice, but of course, in the real world, we may not have access to TDM to all drugs, but at least drugs with narrow therapeutic index, we should do our TDM. Consider interaction with other prescribed drugs because most of our patients, they get a whole long list of drugs prescribed to them. So we need to actively look into drug-drug interaction. And again, this is when we need our renal pharmacist with us. So we review the need for this medication. The unnecessary medication should not be continued. And of course, this is also to avoid us from practicing polypharmacy. It is no doubt that our patients with CKD, they are at risk of medication-related problems or drug-related problems. Owing to the altered pharmacokinetics of drugs and physiology, optimal and safe dosing is an ongoing challenge in CKD care. And some of these medication-related problems can be from drug dosing issues itself, which then leads to ineffective treatment, adverse drug reactions, inappropriate drug selection, and of course, drug-drug interactions, especially when there is polypharmacy. So how do we prevent problems from additional problems or morbidities to our patients? This is definitely not a one-man show. It is not just the clinician. It is also the renal and dialysis nurse. And of course, very important person here in the picture would be the renal pharmacist. We need to have access to dosing assistance, medication reconciliation, to make sure that we prescribe our drugs and adjust them accordingly and safely. So these are my references. Thank you very much and good luck with the polling questions.
Yeah, thank you, Dr. Caroline, for this comprehensive drug dosing, how we initiate the drug dosing and like how we monitor these patients. So I think the questions will be taken after both the talks, isn't it, Dr. Caroline?
Questions will be taken verbally towards the answer.
Answer, yeah. Okay, so we'll move on to the next talk. The next talk is by Dr. Alpana Ohri. Can I have the slides, please?
Yeah.
So it's my privilege to introduce Dr. Alpana Ohri. She is presently the professor and head of the Department of Pediatric Nephrology at BJ Wadia Hospital and the consultant pediatric nephrology at Jaslok and the Bhatia Hospital. She is MUHS certified teacher in pediatric nephrology and a certified transplant nephrologist by the DHS. She is the director of the IPNA recognized training center of pediatric nephrology at the BJ Wadia Hospital. She has many awards to her credit. She is the alumni of the PGI Chandigarh, MD in Pediatrics. She was awarded the best graduate of MBBS studies and All India DNB Gold Medal in the Pediatrics. She has over 30 research publications and authored many chapters on renal conditions in the Manual of Neonatal Care by the Cohorty and multiple chapters in Textbook of Pediatric Nephrology. She's the course director of the IPNA Endorsed Webmaster series in the nephrogenetics, and she's mentor for MD students as well as the pediatric nephrology fellows. Over to you, Dr. Alpana. Yeah. Dr. Alpana, yeah.
Dr. Alpana, you're there around?
Yeah, she's there.
इसको करना और ये बड़ा ही नहीं हो रहा। मेरा स्लाइड शो भी करके दो।
So I think there is a problem. Can we take the questions at the same time till this is resolved, or wait?
Yeah, that should be fine. Dr.
Yeah.
Alpana, is it fine? We'll take up the questions for Dr. Caroline,
Okay.
and then you can be good with your slides.
Yeah.
Yeah, you can please take the questions. I'll just load my slides.
Yeah, at the same time. Okay. So the first question to Dr. Caroline is, please advise how to dose the drugs with narrow therapeutic index, especially vancomycin and Genta, if we don't have facilities to check drug levels in renal impairment. Dr. Caroline.
I think in the situation where we don't have access to drug levels, it will be safer to start low and go slow, because otherwise it will be quite difficult for us to titrate. The only way for us to titrate in this situation would be based on clinical response.
Yeah, that's true, because most of the, like in the low resource setting, this therapeutic this monitoring is not available. So I think this question is quite relevant.
The
And
other the other thing would be probably think of alternative drug.
Yeah, that's true. We can think of all alternative drug based on the cultures or whatsoever. So the second question is there a specific GFR used in AKI called dynamic GFR, or do we need to adhere to the normal GFR calculation methods?
I think in AKI, most of the time when we adjust our drug, for pediatric, if you notice the pediatric references, we would still go by the our bedside shots. But what I should say would be, it should be a trend. It should be a trend, because in acute kidney injury, the GFR changes quite rapidly. But what is important here in drug dosing would be a trend to help us guide us in our dosing of drugs.
Yeah, that's true. So I think we have to monitor this like day to day rather than a fixed GFR we have to choose, especially if the GFR is declining progressively. Okay.
Yeah.
So thank you, Dr. Caroline. So we'll move to the next session by Dr. Alpana Ohri. I think the slides are ready. Over to you, Dr. Alpana.
Hi, is my are the slides visible?
But yeah, they are visible now. Yes.
Okay. Just a moment. Just एक मिनट. In my slide, let this go. Minimize. No, I can't see the slides. इसको minimize कर देते हैं. Okay. Am I audible as well as visible?
Yeah, you are audible, visible.
Okay. So upfront, thank you, Dr. Kalaivani, for giving me this opportunity to speak on a topic which is really close to my heart. And I would request you to give me and not interrupt me and give me my time, because I have presented the way I have understood it, and I have tried to stick as much as possible to the KDIGO guidelines and other guidelines. But I would like to put it up like a story. So please, even if I exceed time, please allow me to go on. So I would be covering the topic under the headings of nomenclature, the definition of CPK-MBD, basics of CKD-MBD, what we have learned from the past and have known for a long time, and what we understand it now. I would cover the normal physiology of the minerals of the bone as well as the vasculature, what goes wrong in CKD-MBD, that is the pathophysiology, the clinical symptoms, how we diagnose CKD-MBD, And what is the treatment? Emphasizing on the principles of management, how adults CKD MBD management differs from children, what are the conventional drugs and which are the newer agents. And for all these things, I would like to cover the minerals part, the bone part, and the vasculature part separately. So previously, what we now call CKD MBD, a couple of decades back was called ROD, renal osteodystrophy, which meant specific biochemical and bone morphological abnormalities directly linked to CKD. But these days, CKD MBD is the new term which is used, and it is meant to signify a systemic disorder of mineral and bone metabolism, which is characterized by any or all of the following. So there are biochemical abnormalities, the features of bone ill health, and their extraskeletal calcifications, often vascular. Which are the biochemical abnormalities which tell you that there is CKD MBD? That is an increase in phosphorus, increase in PTH, increase in FGF23, or a decrease in calcium or in activated vitamin D. With regards to bone ill health, there can be problems of turnover, mineralization, or volume. Nowadays, the term ROD is reserved to describe bone pathology, only the bone pathology, and not the extra osseous issues. So it's always better to learn from the past. So the pathophysiology, diagnosis, and management of MBD in the past vis-a-vis the current understanding of pathophysiology, diagnosis, and management. Now, we have known for a long time that in CKD, there is loss of nephrons progressively. And when a certain critical amount of nephrons are lost, it has a dual effect of increase in the serum phosphate and decrease in serum dihydroxyvitamin D. Increase in serum phosphate directly stimulates the PTH, causing secondary hyperparathyroidism. Decrease in serum dihydroxyvitamin D also increases the PTH, and also via the decrease in serum calcium, there is increase in PTH. So a triple mechanism cause high PTH, and this is the high turnover bone disease. High PTH causes increase in calcium and phosphorus, and when this increases a certain critical amount, there are vascular calcifications. So this has been known for a long time, and also it was known that whenever you treat these hyperparathyroidism very aggressively with calcium-based phosphate binders or activated vitamin D, you develop adynamic bone disease. So therapy also played a role in the bone morphology of what kind of CKD MBD you would have. This has been known for decades. Now, what is new is it's been recognized that the pathophysiology is more complex. Other than these three bone regulating hormones, there's another player, that is the FGF23. Not only that, there are issues with the hormone receptors like the clotho, which is the receptor for FGF23, calcium sensing receptor, and even cytokines and proteins like sclerostin and CPP, which are calciprotein particles. I'm referring to them because I'll be talking about these again and again in subsequent slides. Besides this, what we also know, we have identified the aberrations in the signaling pathways like WNT and RANKL. This is because there are etiology targeted therapies available, newer therapies, which are based on these signaling pathways. So we need to know them. Other than that, environmental factors contribute to CKD MBD. Genetics plays a role. We can have polymorphisms in the genes governing hormones, bone regulating hormones, and which make us more susceptible to a certain kind of CKD MBD. Therapies like before obviously play a role. And what is new is we have to recognize that in adults, there's a big issue of osteoporosis, which acts like a comorbidity in CKD MBD patients. And in children, there are issues with growth hormone, disturbed growth hormone access. So previously, life was simple. We had high turnover disease, osteitis fibrosa cystica, and there was adynamic bone disease. The bone cells known to be involved were osteoblasts and osteoclasts. And if we could not understand anything, we could always do a bone biopsy. But the current understanding is that the bone disease cannot be just talked in terms of turnover, high turnover, low turnover. That's not enough. There are problems with mineralization, which are very common. This may occur as an isolated entity, that is osteomalacia, or mineralization issues can come on top of the high turnover disease when it is called mixed uremic osteodystrophy, and this is particularly common in children. So whenever we talk about bone disease, we have to talk in terms of turnover, mineralization, and volume, the TMV classification. Also recognized as is the fact that it's not only the osteoblasts and osteoclasts, but osteocytes which are a bigger problem. Osteocytes, they are central to the pathophysiology because they are the source of FGF23 and they are the source of sclerostin. And it's also been seen that bone biopsy is now required in a very selected few, because bone imaging like DEXA, peripheral quantitative CT scan, and MRI provide very beautiful images of the microarchitecture. So we don't really require this. Standalone, none of them is good, but combined, they can almost akin to a virtual bone biopsy. Now, with regards to calcification, the old school thought was vascular calcification happens in advanced CKD in a few unfortunate people. These are the ones who have allowed that the calcium phosphate product to exceed the critical value of 65. And so the crystals have deposited in the walls of the blood vessels and in the heart valves. But nowadays, it's been recognized that vascular calcification in CKD is not a passive deposition of the crystals, but it is an active process. And the chief culprit are the calciprotein particles, CPPs, which induce a very pro-inflammatory and a pro-calcific milieu, which causes the vascular smooth muscle cells of the media to undergo an osteogenic transformation and start laying down minerals and calcify. So this occurs in tunica media and has the effect leading to vascular stiffening, increased blood pressure, LV dysfunction, arrhythmias, and even sudden death. With regards to management, what we did in the past is almost similar to what we do now. So the principles of the management have been same. You basically detect changes in calcium, phosphate, PTH, and vitamin D, and maintain all these in the therapeutic on the target range. The difference is previously the treatment was PTH centric. We were controlling secondary hyperparathyroidism with a lot of zest. Phosphate restricted diet, phosphate binders, activated vitamin D, and when all this did not work, parathyroidectomy. Adynamic was managed by reducing the calcium and vitamin D use. And for vascular calcifications, we just tried to keep the product less. But the current understanding, although we recognize that secondary hyperparathyroidism is very important part and parcel of CKD MBD natural history, but the treatment is not so much PTH centric. We in fact allow a little degree of high PTH values. And whenever we are treating secondary hyperpara, we try to correct the treatable causes of secondary hyperpara first. That is hyperphosphatemia, vitamin D deficiency, and acidosis. And only if it's not working, then we use activated vitamin D in a very restricted fashion. When the calcium is less than 9.5, phosphorus is less than 6, we only begin at that time. We use as a monotherapy. And if he's not having the favorable calcium values, we use calcimimetic monotherapy. And if that doesn't work, we combine the two and use dual therapy. Only in patients who are refractory to everything, we consider of parathyroidectomy. Besides this, we also understand that surveillance for vascular calcifications must be carried out, especially in high-risk individuals. And surveillance for osteoporosis also must be carried out in high-risk individuals, especially the older ones, adults. The newer therapies which are available are new kinds of phosphate binders, non-calcium based, and we also try to use more of dialytic phosphorus removal in the patients who are already in CKD 5D rather than emphasizing on diet. There are new calcium mimetics available besides cinacalcid. There is ethyl-calcitide. Anti-osteoporotic therapy is also available, which includes anti-resorptive agents like bisphosphonates, denosumab, raloxifene, romosozumab. There is a role of growth hormone in children. And the targeted therapy or the newer therapy is probably anti-FGF based. Clotho supplements, CPP inhibitors, use of microRNAs to target the aberrant signaling pathways. Now, going on back to the basics, normal physiology. Now, this may seem a little taxing, but I'll simplify. So basically, the minerals concerned are the calcium and phosphorus. And the three regulating hormones are the PTH, the vitamin D, and the FGF. I like to remember that vitamin D is a very happy hormone. It works on the bone to increase bone formation. It works on the intestine to increase calcium phosphorus absorption. It works on the FGF to increase the FGF level on the osteocyte, The FGF, I like to remember again, is a very angry hormone. It inhibits PTH, it inhibits kidney, alpha-1 hydroxylation, and it inhibits the sodium phosphate transporters in the proximal convoluted tubule, causing phosphaturia. The PTH is the balance hormone. It increases the blood calcium, but it increases also the phosphate excretion. So, summarizing, calcium, the vitamin D is a calcemic hormone. FGF is a phosphaturic hormone. PTH is a calcemic and phosphaturic hormone. We also must recognize that children are actually not same as adults. Children exhibit skeletal growth, and they attain peak bone mass at about 18 years in girls and about 20 years in boys. So in general, the calcium requirement in children is higher than that of adults, and even phosphorus is required in higher doses than in adults. So the suggested dietary intakes in children are age dependent. So this is the absolute values of suggested dietary intake, but actually if you go by mg per kg, the calcium requirements are more in the younger children as compared to older children. The other fact which we must remember is that vitamin D deficiency is rampant in the whole world, and especially in children. And how do we treat this nutritional vitamin D deficiency? By calciferol, and it is usually treated for 12 weeks. Dose is 1.8 lakhs in under 1 and is about 3 lakhs in over 1 year of age. So we must realize and recognize that even in normal individuals, the vitamin D deficiency is not treated the age-old fashioned way with 6 lakhs, but it's now restricted to 1.8 lakhs in infants and 3 lakhs in older children. Similarly, the target ranges for the calcium, phosphorus, and alphos are also dependent on the age. Going on to the bone, we must recognize that statural growth happens in girls till 15 years and in boys till 18 years, especially due to endochondral ossification at the ends of long bones. And even in adults, all bones are constantly remodeled. We also should understand that bone is composed of an organic component and an inorganic component. The organic component is the matrix, and the minerals are the calcium phosphate hydroxyapatite crystals. Why I'm emphasizing is because the loss of the organic component is called osteoporosis. Loss of the mineral component is called osteomalacia. And both these are very common in non-CKD children as well. Now, which are the bone cells which are involved? Osteoblasts and osteoclasts. Osteoblasts basically lay down bone. Osteoclasts resorb the bone. The main pathways are, a lot of pathways are there, but the main pathways are the WNT pathway. Significant pathways are the rank L pathways. Now, besides these two cells, as I talked about earlier, osteocyte is a major player. And the osteocyte is actually mature osteoblasts embedded in mineralized matrix. So these osteocytes, they produce FGF23, which is the major phosphaturic hormone, and also secrete a protein called sclerostin, which inhibits the WNT pathways, thus hinders the bone formation. It's actually not so bad. It is actually works to remodel the bones, because somebody has to deposit bone, and some factors have to inhibit bone so that bones get remodeled. So it's for remodeling, this is important. Now, besides these calcium, what we've already discussed, we have talked about vitamin D, PTH, and FGF23 as the major bone regulating hormones. Vitamin D essentially causes bone deposition. PTH essentially causes bone resorption. But here we must realize this is only when the PTH is constantly elevated that you have bone resorption due to PTH. If, on the other hand, there is intermittent exposure of PTH, like when we give synthetic PTH injections to anybody, it doesn't cause bone resorption. It helps in bone deposition. Now, going on to FGF. FGF, essentially, if it's only mildly elevated, it has no direct effect on the bone. It only acts via the phosphorus metabolism. But if FGF levels are very high, severely elevated, it by itself causes bone resorption. Now, besides these three hormones, there is also estrogen, growth hormone, calcitonin, thyroid hormones, which also affect bone health. Glucocorticoids are very important and highly relevant in pediatric practice, because we use it so much in the glomerulopathies which go on to CKD. So these children have been exposed to glucocorticoids for a long time. And any person who has been on a glucocorticoid of more than 5 milligram a day for 3 months is liable to osteoporosis. Here, again, for bone health, other than hormones, other factors like metabolic acidosis is very important, because it causes hypercalcemia, hypercalciuria, and even mild hyperphosphatemia. Other than that, lack of exercise, smoking, alcoholism, high caffeine intake, all affect bone health negatively. This is just a comparison that osteoporosis is loss of organic component of the bone, and malacia is failed to mineralize. Osteoporosis is common in old individuals, postmenopausal, women, diabetics. Diagnosis is by DEXA. You check the BMD. If it's less than -2.5, you call it osteoporosis. It's often silent, presenting only with silent vertebral fractures. Sometimes you can appreciate that the patient has a stooped posture, and there may be mild pain, but not much. And this is treated with anti-osteoporotic therapy, which is anti-resorption therapy like bisphosphonates, denosumab, anabolic agents like the estrogen analogs, and even mixed like teriparatide or romosozumab, which is an anti-sclerostin antibody. Now, osteomalacia, which is more common in childhood, is due to vitamin D deficiency. It is diagnosed by simple biochemical tests: low vitamin D, low calcium, raised alkaline phosphatase. It commonly manifests as bone pains, which are much more than osteoporosis. The significant bone pains can even be myopathy, and long bone fractures can happen, deformities can happen. And we all have already gone through how you treat basically vitamin D deficiency. With regards to vasculature, what we must know is the blood vessels are made up of intima, media, adventitia, 3 layers. Vascular calcification, when we talk about is of 2 types. In atherosclerosis, it occurs in the intima, and in CKD MBD, it happens in the middle layer. Now, the pathophysiology of CKD MBD, because if we understand the pathophysiology, managing will be a cakewalk. Now, first, with regards to mineral dysregulation, then the bone disturbances, and then the calcifications. So what goes wrong is reduction in the nephron number, leading to decreased phosphorus excretion, decreased renal alpha hydroxylase, and low clotho. Low clotho, this is, as I said, mentioned earlier, this is the regulator of FGF. So when this becomes less, FGF rises. And this is the first biochemical abnormality which can be appreciated in patients with CKD MBD, much before this or this happens. So decreased alpha hydroxylase also has other effects. It causes hyperpara. Hyperphosphatemia also causes hyperpara. And hypocalcemia, which is the effect of decreased alpha hydroxylase, also causes hyperpara. So there is no going away from the fact that secondary hyperpara is a part of the natural history of CKD-MBD, and untreated patients with CKD-MBD, majority will have secondary hyperpara when they present. But also, this is a factor which is present in almost all the patients with CKD-MBD, and this causes many problems. Both these hormones, actually, we have talked about them affecting only the bones and the vasculature, but they have receptors on large number of cells, on the cardiomyocytes, on the vascular intima, on the immune cells, inflammatory cells, in the brain, affecting the cytokines, and this in fact produces a lot of inflammation. Now this becomes an issue because in CKD-MBD, as I talked about earlier, genetic renal disease plays a role. For example, if you are having a dense disease and you develop CKD-MBD, that will become an additional issue. Nutrition also plays a role because a diet less in calcium will predispose to osteomalacia. You're taking high phosphorus, you're likely to have more secondary hyperpara. And CKD-MBD parameters also have confounding results. Hyperpara will cause anemia because of osteitis fibrosa, etc. And similarly, biological abnormalities are also in place. The therapy also affects how the CKD-MBD will work. Like warfarin negatively impacts the bone health. We have talked about corticosteroids, and we must recognize that uremia per se is a very pro-inflammatory and pro-calcific milieu, which has a significant effect on the pathophysiology. Now, what goes wrong with regards to minerals? We have talked about hypocalcemia, hyperphosphatemia, hyper PTH levels, and vitamin D deficiency. Now, although we have talked about a lot in circles, but simplistically, what we have to understand is that increased calcium, increased phosphorus, increased PTH in studies has been shown to have increased mortality. Decreased calcium, decreased PTH below the targeted range is also associated with increased mortality. Only the fact low phosphorus per se does not increase mortality except in critically ill. So when we are managing, we are trying to target the normal ranges for all of these things. With regards to bone abnormalities, there is hyperparathyroid bone disease, there is adynamic bone disease, there is osteomalacia, there can be combination of the two mixed, and there is osteoporosis, especially in adults and children who have received glucocorticoids. It's seen in them as well sometimes. What are the symptoms is that secondary hyperparathyroidism causes bone pain, deformities, fractures, even growth failure, slipped femoral epiphysis, anemia, cachexia. Adynamic bone disease most commonly causes fractures, not much pain. Osteomalacia again causes diffuse pain, deformities, and even myopathy. And fractures can happen in all the three. Pathophysiology again of the vasculature I talked about earlier also. It's basically the high FGF, high phosphorus, which causes calciprotein particles to develop. They damage the they cause the vascular smooth muscle cells to transform into osteoblasts, bone-like cells, which start laying down matrix and calcification. So this is how calcification sets it. CPPs or calciprotein particles are a major player. So the effect when the calcium deposits in the media is stiffened vasculature, hypertension, heart failure, arrhythmia, sudden cardiac death. And when it happens in the valves, it can in long-term cause stenosis or regurgitation through those valves. The symptoms, as I've talked about earlier, is dementia. FGF high FGF is known to be associated and cause this. There may be anemia and ventricular hypertrophy, calcification, heart failure, arrhythmias, vascular calcification, gut ill health like constipation. The CKD-MBD per se can worsen the kidney disease by causing fibrosis. High FGF is pro-inflammatory, liver inflammation, sarcopenia, And high PTH2 causes malnutrition because it causes the transformation of the white adipose tissue to brown adipose tissue, and cachexia because of that. There's dysregulation of the immune system and so on. So all children with CKD MBD must have their growth assessed quarterly in infants and 6 monthly in older children, if not possible, at least annually. How do you diagnose CKD MBD? By looking at the CAP-AP, PTH, vitamin D, and bicarb. And KDIGO recommends that we start doing that right from stage 2 onwards. And what is the aim? Maintain all these in the target range. I have put down the targets for different age groups because, as I said, the normal values are different in different age groups. So for CKD stage 2, 3, and 4, maintain calcium in the target range, phosphorus in the target range, bicarb like in CKD MBD 22 to 26, and the vitamin D 30 to 48. And in CKD 5, you try to avoid the upper levels of normal. Even within the normal range, try to keep around 9.5 on the lesser side. Similarly, for phosphorus, try to keep on the lesser side. Again, these are adult values. There's nothing I got from any of the recommendations, including KDIGO 2017, on what the precise value is. So this is the adult value, which I think for CKD stage 5 is a good value to follow. And what is surprising it is that we don't target the PTH so tightly like we used to. The KDIGO says that even up to 2 to 9 times of upper limit of normal in CKD stage 5 is permissible. And roughly some other text literature says that you try to target between 200 to 500 in CKD stage 5. So the upper limits are still debatable. Lot of guidelines, all controversial. This is what I'm trying to say. The values, the KDIGO per se only they keep changing. For sake of simplicity, I've tried to incorporate multiple things and assemble this table. Here, I found urine calcium creatinine ratio following up these children to be a very useful parameter because it tells you the acidification control that you're exhibiting as well as if you're exceeding your vitamin D levels by urine calcium creatinine. So what is significant is we have talked so much of FGF23 being the big villain in our story, but why can't we not measure only FGF23 as a biomarker for early CKD MBD? So probably in times to come, it will start using it more often. But as of now, it's an expensive modality and there is a diurnal variation in its levels. So it's not used very commonly, but sometimes even we have used it. Now, how do you diagnose the bone disease? Again, we just use the blood biomarkers. High turnover disease is suggested by high PTH and high serum alkaline phosphatase. Low turnover by low PTH and low serum alkaline phosphatase. Mineralization defect by high PTH, low calcium, low vitamin D. And if you want to go a step further, do a lateral view of the abdominal X-ray. You can diagnose the vertebral fractures, which can be asymptomatic osteoporosis, which are there. And at the same time, you can also pick up aortic calcifications. So CKD, the KDIGO guidelines, they don't really say that you start doing skeletal surveys for picking up CKD, MBD, bone disease in children. But they say in high-risk individuals, it is worthwhile doing the abdominal X-rays lateral view. DEXA for BMD assessment, again, it's not recommended as a surveillance tool, but in adults, it may be done in those who are at risk for osteoporosis, meaning they've had vertebral fractures or long bone fractures. In those individuals, you do DEXA for BMD assessment. In children, as I've said, osteoporosis is not very common unless they are on steroids or they are already having a GIA other than the CKD, MBD, or there is a family history of osteoporosis, etc. These are all things that I could muster from various specialists. And how do you treat it? Only these individuals are actually candidates for anti-osteoporosis therapy, which I'll be covering shortly. So other than this, there's no really need of checking the bone turnover biomarkers or peripheral quantitative CT scan, MRI, etc. That's not required. Bone biopsy, again, very few indications, because we can do very good imaging instead and pick out the bone architecture, microarchitecture details. Now, for extraskeletal calcifications, again, abdominal X-ray lateral view. Again, it will pick up aortic calcifications also, and you can pick the asymptomatic vertebral fractures in the patients who are having back pain, etc. And 2D echo for valvular calcifications. Now, KDIGO 2017 says that in high-risk individuals, both of them can be done. And additionally, 2D echo also for left ventricular mass index. Now, additively, if you are for example, you're studying CKD MBD, you can use sonography to pick up CIMT, the carotid intermedial thickness, and also check the pulse wave velocity. There are guidelines, parameters which are given, and you can compare and find out if you are having extraskeletal calcifications. Now, why, if there's no specific therapy as of now for extraskeletal calcifications or vascular calcifications, why are we trying to diagnose all this? This is because if we identify individuals who are having these vascular calcifications, we can completely avoid calcium-containing phosphate binders in them. And also the fact that in times to come, possibly targeted therapy based on CPP or phytoin A supplements, etc., may become available in times to come. Management. What are the principles? Adult versus children, non-pharmacological therapy, available drugs, and recent advances. Now, management is basically management of secondary hyperpara using phosphate binders, first phosphate restricted diet, or using binders, calcium based or non-calcium based. Whenever we are using calcium based, we must factor in the calcium load by these binders. Then the other receptor, the calcitriol, activated vitamin D analogs, which includes rocaltrol, doxycalciferol, and paracalcitol, calcimimetics, cinacalcit, and etylcalcitine. So essentially, the parathyroid gland has receptors for phosphorus, calcium, and vitamin D. So we act on all these three: calcium, calcitriol, and calcium sensing receptor. Now, for adynamic bone disease, which is associated with low PTH, high calcium, stop vitamin D analogs, stop calcium-based binders, and use low calcium dialysate. Also, we can use synthetic PTH, which is recombinant PTH, which is teraparatide, and there is also abaluparatide, which is also a synthetic PTH analog. Additionally, romosozumab, which is an anti-sclerostin antibody, may be used if you're having adynamic with osteoporosis. It will have the dual effect. Osteomalacia, we have talked about. Vascular calcification, we have talked about. Growth hormone, we will cover in some time. And anti-osteoporotic therapy, anti-resorptive therapy, which is bisphosphonates, which inhibit osteoclasts. Demosimab, which is a monoclonal antibody against RANKL. Riloxifene, which is an estrogen modulator. Teraparatide, abaloparatide. Romosozumab, which is a monoclonal antibody against sclerostin. So additionally, when we are managing hyperpara, we must consider that early transplant would be the best bet. Uremia must be better controlled. Acidosis is better controlled. When comparing the adults with children, we know that adults, the main therapy relies on managing secondary hyper and anti-osteoporosis therapy. So again, the same thing, but in adults in general, they don't prefer the calcium-based phosphate binders. They directly go on to non-calcium-based phosphate binders. And there is more generous use of calcimimetics vis-a-vis the children. And anti-osteoporotic therapy obviously is a very important part of the regime, managing regime. Now in children, because we need calcium and phosphorus for accruing the bone mass and skeletal growth, so we are not so strict about always using non-calcium based binders. We can use calcium based phosphate binders also, provided we take into consideration how much the blood calcium, how we are maintaining, and if we are not overshooting the target range. Similarly, calcimimetics can be used in children, although they are not licensed for use in under 3 years of age, but they can be used if you are specifying the criteria for calcimimetics. Vitamin D repletion is very important. Growth hormone therapy is important when managing CKD MBD in children. And there's very limited use of anti-osteoporotic therapy in children. So again, the management basically of secondary hyperpara is limiting the dietary phosphorus intake, the permissible levels for calcium intake, which is 2 times permitted of the SDI, suggested dietary intake, which is inclusive of diet, drugs, and dialysis. These are the values which are there. For the phosphorus intake is what the SDI for phosphorus is. And for the vitamin D is about maintenance vitamin D is 800 to 2000. Roughly we catch 1000. So additionally, when you're managing the diet, and we must factor in the dialysis bit also, because when we are curtailing phosphorus in the diet, we end up curtailing proteins as well, which is very negative for children. So CKD 5D who are on dialysis, it's better to increase the efficiency of your dialysis to remove phosphorus rather than limiting the protein intake. Now we must remember that one HD session removes out 800 milligram and 1 day of PD removes about 400 milligram. So these are the manipulations which are possible. And when we are correcting the vitamin D deficiency, how much vitamin D to give depends upon the values. Less than 5, severe deficiency, in or mild deficiency or insufficiency, and we use cholecalciferol, which is used. So roughly the doses, all therapies completed within 12 weeks, just like in normal children. The cumulative dose here is about 4.8 lakhs. It is 3.6 lakhs in this mild deficiency, and insufficiency is 1.8 lakhs. So it's about weekly for 4 weeks, and then fortnightly for 4 doses. Then this is fortnightly 6 doses, and this is monthly 3 doses. So whenever we are giving vitamin D in the replacement doses, we must check vitamin D after 3 months to know that we have achieved the target range. And while they are on therapy, you could monitor the calcium creatinine ratio to understand if we are overshooting or under treating, etc. And there are some recommendations that if the values of vitamin D overshoot 48, you can withhold even the maintenance vitamin D for some time in such individuals. With regards to phosphate binders, calcium carbonate, calcium acetate, all of us are aware. We must just remember that calcium acetate is more efficient as compared to calcium carbonate with regards to phosphorus removal, causes less calcium loading as well. And Sevelamer is the non-calcium based phosphorus binder, which is used most often. 20 to 40 mkd is the dose, 8 hourly. It is a non-absorbable hydrogel which removes phosphate and without increasing the calcium levels. Additionally, what is new is the ferric citrate, iron-based phosphate binders, ferric citrate and sucroferric oxyhydroxide. This is very useful because it delivers iron as well. Iron requirement decreases by 50%. This actually doesn't add much iron to the body. So this is more of a just the calcium sparing phosphate binder. So Tina Penor is something which is something we look forward to. It's a new kid off the block. So it is just like, it's again an ion exchange resin, works on sodium hydrogen channel in the intestine, and decreases the paracellular calcium phosphorus absorption in the GIT. It's still in trial phase, but seems to be working well. When we compare whether to give a particular child activated vitamin D for control of secondary hyperpara or use a calcium mimetic for control of secondary hyperpara, we must take into consideration the serum calcium and phosphorus levels to decide. If the serum calcium is less than 9.5 and serum phosphorus is less than 6, then it is better to start activated vitamin D analogs for treating the secondary hyperpara. Again, I'm stressing, you have already corrected the acidosis, you have corrected the vitamin D deficiency, and you have corrected the high phosphorus intake in the diet first. And then you have come to the second stage of going on to drugs. And here you will want to use activated vitamin D only if your calcium pre-treatment is less than 9.5 and phosphorus is less than 6. This value is 5.5 in adults. So in children, it's about 6. This is because when you give activated vitamin D, you're going to cause calcium absorption and phosphorus absorption, and these values are going to surge. So additionally, when you're using activated vitamin D, it makes sense that you combine it with a non-calcium based phosphate binder. So make sure that you have switched to a non-calcium based phosphate binder if you're using activated vitamin D. On the other hand, if your serum calcium is less on the lesser side, if your serum calcium is okay, it's more than 8.4, you could use calcium mimetic. So if you have tried monotherapy of either of the two things and still you have not reached your target's PTH, still the PTH is outside the targets, you can even use the two together, combination therapy. Now, what is the dose of activated vitamin D and what is the dose of the calcium mimetics? With regards to activated vitamin D, in smaller children also it can be used under 10 kg, one capsule twice a week, 10 to 20 kg, one capsule alternate day, more than 20 kg, one capsule OD. And when it's older individual, we take into consideration what is the level of PTH to decide on the activated vitamin D dose. If it is between 300 to 500, we use 0.5 micrograms. If it's 500 to 1000, 1 microgram, more than 1000, even 2 micrograms can be used. But beyond this, you should not go, especially if you are going, if all this is leading to hypercalcemia, etc., then combine this with cinacalcet rather than go on increasing your vitamin D, activated vitamin D. Now, with regards to cinacalcet, the dose is 0.2 mg per kg per day. And what we have to remember, this is the same value irrespective of PTH levels. So you cannot start with more than 0.2 mg per kg per day, even if your PTH is over 1000. And once you start, the dose can be increased monthly only. You cannot escalate it fast also. Maximum dose permitted is 2.5 mg per kg and a maximum 180 milligram per day. This is because the hypocalcemia can be quite severe if you start calcium mimetic. It occurs in 10 to 20%, but it can be significant. And sudden deaths have been reported with cinacalcet use. And that is why it's not licensed for use in under 3 years of age. And long QTC syndrome, etc., can also happen. So other newer activated vitamin D analogues are paracalcitol and doxycalciferol. And with regards to the newer calcium mimetics, there is etylcalcitide, which is available as IV also. And it has the advantage of having a very long T-half. So it improves compliance. So the question comes, when you are in between 8.4 and 9.5, which one to choose, activated vitamin D or calcium mimetic? So there are no definite guidelines, but in children, considering that cinacalcet can be life-threatening, it can cause sudden death, etc., and not licensed for use in under 3, maybe going on with vitamin D analogues with a non-calcium-based binder may be the best bet. As I've said before, if whichever therapy we have chosen according to your serum calcium levels, if it's not working and you're not achieving the target zones, then combined therapy with active vitamin D and calcium mimetics can be used. Growth hormone therapy indications are CKD stage 5, 3 to 5D, or even 1 year post-transplant only in individuals who are more than 6 months of age, when they're failing their height age is less than 3rd percentile, growth velocity is less than 25th percentile. And whenever you are starting growth hormone, you must check that they're having open epiphysis, PTH is less than 500, there's no critical illness or malignancy, and they have a stable fundus, no proliferative retinopathy. The dose is 0.15 units per kg per day, subcutaneous injection. It's given in the evening, and a total at least of 6 months therapy is given. On follow-up, we monitor all these things, and we stop therapy if there is epiphyseal closure or there is poor response to treatment. That is, even less than 2 centimeter height gain after 1 year of therapy is poor response. We do not continue growth hormone in that situation. The newer drugs, this is the last slide, second last slide, sorry. So please give me just 2, 3, 4 minutes. So with regards to newer therapies, the relevant in children are the new phosphate binder I have already covered, that is tenapanor, and a new calcium mimetic, which is etylcalcitide, which is a longer duration of action, and IV preparation is available, can be used in HD patients during the dialysis session. Other than that, the whole number of anti-osteoporotic therapies which are available, which are very limited use in pediatrics. We only studies which are available in children are of bisphosphonates. This is because a lot of experience is available on bisphosphonate use in osteogenesis imperfecta children. So as pediatricians, pediatric nephrologists, we're most comfortable, and this is the most studied drug in children. The problem with bisphosphonates is, besides the side effect of causing very atypical fractures by their own self, they cause, by bisphosphonate therapy causes atypical fractures, and also osteonecrosis of jaw, esophagitis, etc. All these issues are there. And the worst problem is that these drugs are renally excreted. So their values increase in CKD, and they themselves can cause adynamic bone disease. So a lot of problems of using bisphosphonates as anti-osteoporotic therapy in CKD MBD, maybe only if we document that there is if there is a vertebral fracture and we have ruled out all other treatable causes of osteoporosis, optimized CKD MBD, proved that there is osteoporosis with your DEXA scans, and we have factored in everything, the dose adjustments, etc., and we have confirmed that there's no adynamic bone disease, then maybe bisphosphonates may be used. But otherwise, it's a risky proposition. Going on to denosumab, it is used in adults, not studied in children. It's safer than bisphosphonates in CKD, and even advanced cases can be used in adults. Problem is hypocalcemia, and so this is the main issue. In aging women who are having osteoporosis, who have lost the estrogen, giving them an estrogen analog like roloxifene would do wonders for their bone health. And it's been studied in hemodialysis, adult hemodialysis patients. But problem is, it may exacerbate the hot flushes, and venous thrombosis may occur with them. Teriparatide is a synthetic PTH. As I've told you, when you give PTH intermittently, it helps bone health. It causes bone formation. So you give teriparatide in women, in osteoporotic CKD individuals having adynamic bone disease, it will work. But a problem is hypercalcemia, and rarely osteosarcoma can also happen. And romosozumab is another drug which is anti-osteoporotic. It is actually it is a very good targeted therapy for aiming. It's an anti-sclerostin antibody. Somewhere I've written anti-sclerostin antibody, a good example of targeted therapy in CKD MBD, anti-osteoporotic. The problem is cardiovascular disease can happen, sudden cardiac deaths, etc. have been reported with this, because sclerostin is not a villain always. It is useful in the cardioprotection also in individuals. So, and this especially is useful in adynamic bone disease CKD patients. So I would like to summarize my presentation that CKD MBD is actually a systemic disorder of disrupted mineral and bone homeostasis, characterized by abnormal biochemistry, abnormal bone structure, and ectopic calcification. In abnormal biochemistry, there is high phosphorus, high PTH, high FGF23, low calcium, and low vitamin D. When we talk about bone structure, we talk in terms of turnover, mineralization, and volume. And ectopic calcification occurs when high phosphorus occurs, and it is complicated by high calcium exceeding the product. The pathophysiology primary problem is high serum phosphorus, which happens due to decreased GFR, which leads to secondary hyperpara and high FGF. These occur actually, to start with, these are adaptations by the body to increase the phosphorus load by causing phosphaturia. But over time, these alterations are not enough, because nephron loss is getting progressive in CKD. So these adaptations are not enough. And with time, these rises in PTH and FGF, which were adaptations initially, they become maladaptations because they become exaggeratedly high. And this is also because their receptors become less, clothos become less, PTH receptors, they downgrade. So the levels of PTH and FGF become too much. And both these are basically toxins to the vasculature. So high PTH and high FGF produce a lot of effects on the heart bone vasculature. And these are the symptoms of CKD MBD. So additively, when you give calcium to such individuals, you add fuel to the fire and exacerbate the vascular calcifications. So how do you evaluate and classify? It's on the blood levels of CAP-AP, PTH and vitamin D. And probably in times to come, we will start monitoring FGF23 as an early biomarker. DEXA scan only when the risk of fractures is high and there is high predisposition to osteoporosis. Bone biopsies very rarely, because high resolution imaging is virtual biopsy. We must recognize that mineralization defects are common in CKD, especially in children, and it occurs due to vitamin D deficiency, which must be treated first. Bone health and ectopic calcification can be checked by abdominal X-ray lateral view and 2D echo. With regards to management of CKD MBD is treatment of secondary hyperpara, first by restricting the phosphorus, correcting the acidosis, and correcting the vitamin D levels. There is very restricted use of activated vitamin D, which must be done, and only when the calcium is less than 7.5 and phosphorus less than 6. Calcimimetics may be more suitable when the calcium is more than 8.4 and can be combined. This can be combined with the calcium-based phosphate binder. If none of them are meeting the target's monotherapy, combined therapy can be used, and parathyroidectomy is needed only in refractory cases. Growth hormone has a role in pediatric CKD, and addition of anti-resorptive therapies may be useful in adult CKD having osteoporosis. In future, targeted therapies modulating FGF axis like clotho supplements or microRNAs, which are basically hitting the different pathways, signaling pathways, may be available in the future. Thank you.
Thank you, Dr. Alpana, for excellent talk and excellent. Okay, so Caroline, can we take some questions? I think.
Sure, sir. Can we take few questions alone, because we are already late? It's time.
I'll take some few questions.
Yeah.
Okay. So the first question is, I think it's a simple one. At which pH level give the child with CKD sodium bicarbonate? So at which bicarbonate level one should start sodium bicarbonate in the patients with CKD?
Okay. Yeah. So in general, in children, we know that the target bicarbonate is 18. In older individuals, is about 22 to 26. So it's 22 is what we target commonly. So if you are having the right age, depending upon your age, if you're not having the bicarbonates in that level, especially if it's coupled with less pH and clinical symptoms of failure to thrive, etc., you will start oral alkali therapy. And here I would just like to additionally say that when you are using oral alkali therapy, it has to be soda bicarb. You can't use soda citrate in children because citrate accumulates in renal failure.
Yeah. The second is, how should the calcium carbonate be taken when it is given as calcium supplementation? I think based on like with food or
Come again, I couldn't get how to what?
How should the calcium carbonate be taken when it is given as calcium supplement, not as phosphate binder, along with food? Exact advice to the patient, please.
In general, as I said, the whole pathophysiology of CKD MBD starts and ends with hyperphosphatemia. So I think using calcium carbonate as a calcium supplement when your phosphorus, etc., is in a very good range, that scenario is less likely to arise. And if it is arisen, in fact, you should be worried if your serum phosphoruses are so good that without binders, the child is having PEM, because if less phosphorus intake, less protein intake. So you are in trouble. But anyways, coming to the question, if you say that there is less phosphorus is bang normal without any phosphate binder, the child is not even PEM, you just want to give calcium, then you give it in between the meals.
Yeah. So it's empty stomach. If you want to increase the calcium as a binder, you have to give.
Yeah, one more thing here. Whenever you're using calcium, you cannot use soda mint at the same time, because calcium needs acidic pH for absorption. If you are giving the soda mint at the same time, then it will not happen. So if it's empty stomach is not possible, at least don't make sure they don't give it with soda mint.
So next question is, what are the indication for calcium lactate? I think he want to write calcium acetate in MBD, calcium acetate or calcium carbonate in mineral bone disease.
So when do you start? Is that what you mean?
Acetate, calcium acetate, calcium acetate versus calcium carbonate. Or
yeah. So when do you start which? Is that what you're saying?
Calcium lactate he has written. It's calcium acetate, I think, because lactate we usually don't use.
Understand, but what does he want to know? When do we give calcium carbonate and when do we use calcium acetate?
Acetate, yes.
So in general, if you are wanting calcium acetate is preferable, because it causes less hypercalcemia for each amount of phosphorus that you bind. So it's 60% less hypercalcemia as compared to calcium carbonate. So roughly I had calculated that in adults, if you factor in what is the permissible level of calcium in a day, you can use up to 6 tablets of calcium carbonate and 9 tablets of calcium acetate. Adults, I'm talking about. In adults, the permissible calcium intake in a day is 2.5 grams, including diet, drugs, and dialysate. So, in factoring in that, how many tablets in a day are permissible? I had done the calculation. It's 9 tablets of low phos in a day and 6 tablets of calcium carbonate in a day. So you can put this analogy to simplify things. Am I clear?
Yeah, I think the bottom line is that if we give calcium acetate, the risk of
you can use
will be low.
less hypercalcemia vis-a-vis calcium carbonate, which is more hypercalcemia.
One question. So if we get a child with marginal hypocalcemia, vitamin D insufficiency, normal phosphate, and high PTH 3 times in CKD stage 4, what would be the initial management? Should it include calcium supplement, vitamin D supplements, and active vitamin D3 all? Or do we need to correct vitamin D deficiency first and then later to start other?
Oh, sorry, I've lost it. Long question.
Yeah, so what you want to say that suppose in a patient with marginal hypocalcemia, vitamin D insufficiency and normal phosphate, but high PTH. Okay. So how we should go with this patient? What we should like supplement first, or all three altogether? This is what he wants to.
So always, if you are having high PTH, meaning you are having secondary hyperpara, you always must correct the vitamin D deficiency first before going on to activated vitamin D or calcium mimetic. Obviously, the first thing is correcting the vitamin D deficiency here. Now, how much vitamin D you will use? I've given it here. It depends. 3 months therapy, depending on whichever your value is, you will use vitamin D in that range. If there is also hypocalcemia, if your serum calcium is less than 7.5, you have to give shell cal also 50 to 75 mg per kg for 3 months. If it's between 7.5 to 9, maybe you can use a very small dose, because we don't advise routinely calcium with vitamin D, because anyway your vitamin D is going to increase the calcium and you will exceed the targeted values if you are just giving calcium unabated. So, but if it's severe hypocalcemia less than 7.5, corrected calcium, then calcium and vitamin D has to be given. Here, this is the chart which is given how much to give depending upon your vitamin D levels.
Yeah. So next question is, what is the role of low dose steroid in managing tertiary hyperparathyroidism?
What is the role of what?
Steroids, low dose steroids.
For managing tertiary hyperparathyroidism.
Yeah.
Now, tertiary hyperparathyroidism, I have not come across any steroids or anything. Here, I would like to, for the audience who are not familiar with tertiary hyperpara, I would like to just share this slide here. Now, we know that parathyroid glands have all these 3 receptors. So when we are controlling it, we are using these 3 receptors, block it. In secondary hyper, all these receptors are working, although they get slightly downregulated. In tertiary, because one nodule has become so much hyperplastic that these receptors are lost. So all these drugs, they work less, but it's not that they don't work. So dual therapy would work. And if dual therapy is also not working for after a while, then surgical parathyroidectomy with autotransplantation is better. I have not come across any literature of steroids being used, because PTA, this gland doesn't have steroid receptor. How will glucocorticoids work? I don't understand.
Yeah, okay. So Dr. Kalavani, shall we conclude? I think we are running out of time, or we can take questions.
I think we can conclude and move on to the polling session, sir.
Okay. So thank you, Dr. Alpana, Dr. Caroline, for this excellent session, and Dr. Kalavani for the opportunity for moderating this session. Over to Dr. Kalavani.
Thank you so much, Girish, sir. Thank you, Dr. Alpana. It was an excellent presentation. Thank you so much, Dr. Caroline. Like, I know it's very late for you. If you are interested, you can join for the polling session. Otherwise, you're good to go. Thank you so much, Caroline.
Thank you.
Thank you, Girish, sir. I think now we move on to the polling session. Dr. Alpana, can you please stop sharing your slides?
Yeah. Yes. Okay, stop sharing. Stop sharing.
Sorry for the delay. Now we will move on to the polling session. So it is a routine instruction. All participants are requested to enter their proper email ID, and we request all participants to enter the same mail ID and not to use different mail IDs, because we'll have difficulty in actually selecting in the final round. So this would be the 5th polling session, and the next polling session is the final one. We have 10 questions this time, and we have 5 minutes for the session, and we have 4 star questions, and that would be considered only in case of tie. And the cumulative score is going to be taken for the final scoring chart. I think we are good to go for the polling session. Can we have the questions? We have got 3 more minutes. One more minute. Can we close the polls? We can stop the polls. Once again, thank you all. Probably the next session will be on April 30th, and that session will be the last polling session. And we'll be ending up this webinar series on May 3rd. It will be the last session. Thank you once again. Thank you, Dr. Caroline. Thank you, Dr. Alpana, and thank you, Dr. Girish. Thank you so much. I think we are good to close the session now. Thank you all.